All right, we'll go ahead and get started with our next presentation. We have 3 speakers for our next presentation. We have Dr. Craig Watkins, professor in the School of Journalism and Media and director of the IC² Institute. And Dr. Watkins is joined by Sookja Kang, a doctoral candidate in the School of Nursing, and Tu-Quyen, an undergraduate pre-med biochemistry student. And the 3 of them will be speaking on responsible uses of generative AI, the future of clinical reasoning.
I keep forgetting to turn my mic on. So anyway, excited to be here and looking forward to sharing with you one project that we've been working on and are super excited about at IC². And Sookja and Tu-Quyen have been really central to this project. And so I'm happy to be able to present this work with them. So just we thought it might be useful to provide a little bit of context, and I'll do that. And then Tu-Quyen and Sookja will get into some of the more specific aspects of the study and some of the work that we're doing, where we're sort of framing some of the empirical analyses. I would say that this work was really inspired by a series of conversations that we both had internally at IC². Always informed by good systems and really sort of thinking about, ethical applications of AI. What we've been thinking more and more about is, applications of AI in the healthcare space, healthcare context. And as we were just discussing on a prior panel, the stakes are obviously really high, in healthcare. And what was of particular interest to us, among other things, was we were coming across both academic research, peer-reviewed research, and then news reporting of clinicians experimenting more and more with large language models, right? So like all of us, right, clinicians too are trying to basically sort of understand, what are the prospects for this technology, right? How might it in some ways enhance our ability to deliver safer, more effective, more responsible care? But also, right, what are some of the concerns associated with that? And some of the research that we were coming across, right, were the ways in which they were sort of learning about the ability of large language models, for example, to be just as good, if not better than clinicians at doing diagnostic reasoning, right? And so in terms of measuring accuracy, in terms of measuring quality of diagnoses, a number of these experiments, right, were suggesting, again, that this technology was beginning to meet and in some cases surpass clinicians' ability to sort of do this work. And as we'll talk about later, when we began interviewing clinicians about this, they were saying very similar things, right? That they sort of see a not too distant future where this technology will in some ways be able to do diagnostic reasoning and even management reasoning, right? So diagnosing is, as a patient presents with certain symptoms, and then how do you begin to go through a series of processes, differentials to sort of understand what's happening. But then there's also management reasoning, right, which is a very different kind of challenge in terms of understanding, how do you help a patient through treatment, right, and what decisions do you make? And so that was one sort of aspect, right, that informed this study that we'll talk about today. The other one, right, was this increasing conversation around the way in which AI will impact the future of healthcare, and work more generally, but healthcare specifically in terms of what we were interested in. And in particular, right, we found ourselves sort of gravitating towards research, gravitating towards a conversation around not so much of AI replacing doctors, but rather AI changing the way in which doctors perform their jobs. I think that's really sort of an interesting component that oftentimes gets overlooked, and we really wanted to sort of explore that in some depth and some detail, and some of the work that Tu-Quyen and Sookja will talk about will sort of describe that. And specifically, right, thinking about, right, again, how the content of work, right, what doctors actually do as they begin to integrate these technologies into their workflow, into their decision making, and what, what's happening as a result, right? And so we kept coming across the challenge, and it came up in our interviews, it comes up in a lot of our research. One of the threats among many, right, is that over-reliance on AI might, right, lead to, certain kinds of outcomes that we may not necessarily want. And so I'm going to stop there because I think I'm getting into your area. And so Tu-Quyen will talk a bit more about what we've been up to.
Yeah, hi. So thank you, Craig, so much. And so all great points there, right, that speak to what we've been working on. But so working alongside AI has proved to greatly benefit, right, nearly all domains of work in terms of what we do or produce, right? So it increases efficiency, improves accuracy, but it's largely unknown, right, how it will affect how we do all of that. So how, referring to, the cognitive process that you have to go through in order to execute that, in order to come to a final decision or a final product. And, this question matters not only in moments that these systems might fail us or they become unreliable, but in the importance of maintaining that human interpersonal trust and that human expertise that is so important to the professional world, right? So to kind of preserve the sense of human agency and prevent this cognitive offloading, we kind of have to ask, when AI thinks for us, what happens, or like how does that affect how humans think? And so that first headline there was a study we came across really early in our work. That it was a study done last summer, and a group of researchers at MIT took groups of, like this big group of human participants, separating them into 3 different groups, having them all perform the same task of writing an essay. And so one group was allowed to use ChatGPT, the other group was only allowed to use a Google search engine, and then the final group was allowed no resources at all. And so they wanted to monitor the brain activity of these individuals during the duration of this task. And they found that the group that had the lowest brain activity was actually the group that was using ChatGPT. And so, yeah, surprise, surprise. And so kind of along the same lines, but shifting to a healthcare perspective, that second headline there was conducted a few months later, I believe, and it was an observational study where researchers studied endoscopists, and they found that their adenoma detection rates actually decreased significantly when they stopped using AI after having used it for several months, I believe, to detect these precancerous polyps during a colonoscopy procedure. So, that kind of sparked some public uprising, some media conflict, and that New York Times article came to question, is AI making doctors worse at their jobs? And and all these headlines kind of come to tie together that AI has the potential, it may actually dampen your cognitive effort and produce a decline in skilling. So, yes. And when we talk about skilling, we're referring to, again, that cognitive effort that has to be exerted in order to execute a task, right? So when we're talking about, in the context of healthcare, we're talking about clinical reasoning. So this is an article from Lancet that kind of asserts this decline in skilling into 3 different categories, where deskilling kind of assumes that clinicians are offloading their reasoning tasks to automation, right? So this causes their clinical reasoning skills to atrophy. Misskilling refers to maybe a shift in skills that can lead one down the wrong path, right? It can lead to ineffective knowledge or information that results in the erosion of maybe some type of vigilance that makes one more susceptible to these hallucinations and biases that AI is so popular for, And then never skilling, meaning not at all, right? It kind of refers to the population of clinicians in training that they're training in AI-augmented environments, which cause them to maybe never develop these skills at all. So the clinicians that we interviewed over the summer, they definitely expressed these concerns, right? These concerns that AI is encroaching on this cognitive engagement, clinical reasoning skills. And that's exemplified by the quotes below each of those skilling definitions there. And this really goes to show, right, that this problem isn't theoretical, that it is a real-world issue that clinicians are actively working to address and mitigate. So in our work, right, yeah, we're trying to show that, how they're doing that.
Okay, so with all these concerns and questions, we conducted a research project last summer and interviewed 19 clinicians across states. And what we identified shows the workflow, how clinicians actually use AI tools for their clinical reasoning. And as you see here, it looks very clean, 4 phases. However, in the real world, it can be very messy and blurry. And today, I'm going to specifically talk about phase 2 and phase 3, how clinicians interact with AI systems and how clinicians actually validate and evaluate the AI outputs before they make it applicable for patient care. So phase 2 is talking about how clinicians are actually using AI tools for their clinical work. And when we think about AI tools, without humans' input, it's not gonna generate anything. So if you put bad inputs, it will spit out bad outputs, which we all have experience with. So it is very important to learn about those skills and apply into the clinical practice. And the quote is very good example about using ambient listening tool, which is a recording AI tool for the conversation between doctors and patients. And without clinicians verbalizing the examination that they are doing on patient body or anything else, what's going on they are observing in the patient condition, without their verbalizing, the AI tool won't be able to capture the record and then not going to put in the patient information. So the clinicians are actually reskilling to adapt these AI tools to effectively use these tools in their clinical practice. And next one is phase 3, talking about how clinicians are actively evaluating and validating the AI outputs before they make it applicable for their clinical decision making. So for example, there's one fellow clinician who was very fixated using AI tools. And he took the face value of whatever AI generated. But senior clinician found out that there was a gap, that it was not aligned with what's happening with the that patient case. So they had to review and go through what's happening and then found the gap. So they both learned that even though they provided proper inputs for the patient cases, however, it's always important and critical part for clinicians to go over and review the AI outputs before they make any clinical actions for patient care. And final thoughts?
Yeah, so I think what you see here is, to the point that Tu-Quyen and Sookja were making is, we recognize, right, that this threat of deskilling is real. It comes up in the literature. It came up repeatedly in the interviews that we were conducting. In other words, right, clinicians are aware of the possibility of becoming over-reliant on these technologies and how it might lead to an erosion of cognitive engagement, reasoning skills, and just their own capacity, right, to develop the proficiency expertise that's required. And what struck us, right, in terms of, what we were learning from these clinicians is just how intentional they are about mitigating that risk, right? And so these phases, right, that Sookja talks about, right, are just, it was our way of trying to develop like a framework or a heuristic device to really sort of understand what she noted, right, is a very dynamic process, very interactive. But it begins to allow us to sort of understand in isolation how these things are happening, right, across the sort of clinical workflow in terms of, the degree to which this is happening. The other thing that struck us, right, is this idea that as we think about, the future of healthcare as we think about the ways in which these systems will be integrated into the clinical environment, again, the kinds of skills that will be required, right, to sort of navigate these technologies. And so for us, right, it sort of represents, right, this sort of reskilling process, right? So there's a threat of deskilling, but there's an alternative, right? And that is reskilling, upskilling. In some cases, right, developing whole new kinds of skills, right, novel skilling, because of the ways in which these technologies introduce new kinds of conditions, situations, opportunities to sort of practice and respond and work with patients in entirely new ways. And so we were struck by this. And I don't know if each of us, right, have sort of a takeaway in terms of an implication, but we're thinking a lot about like the future of medical education. We presented some of this work to the medical school. They're very interested, right, in terms of what this might mean regarding how they prepare, develop, and train medical students, right? And so we have a pre-med major on our team who we feel like sort of represents, right, what this future will look like. And so in other words, right, how do you sort of begin to start building a curriculum? How do you begin to start building like pathways and a trajectory that help people sort of develop these skills, right? It's also, it's a mindset, it's an understanding of how to sort of struggle with these technologies and use them in ways that really do contribute, right, to sort of developing whole new kinds of skills.
Yeah, so as an undergrad, I feel like right now we're just like all resisting that temptation to use AI to just get it done faster, right? But educators and everyone actually being cognizant of this large implication that AI might have on learners is really important, because going into med school, right, you not only want to just have better outputs, you don't just want to do better, you want to be better, right, for your patients. There's a lot of things at high stake there, so I think this work is really important.
So in my point of view, when I think about all those, like the process that we identified, the clinicians goes through, and reskilling and mediating the deskilling aspects, how it can be applied in the medical education system to be able to adopt the tools for future generations. So Craig is actually doing some research projects with Dell Medical School about this kind of aspects, and we are very excited about learning about this project.
Yeah. They'll ask us questions. Any questions?
This was such a great talk. Thank you so much. Oh, okay. Thank you. This was a great talk. Thank you all so much. One of the things that I'm curious about is that it seems like this deskilling applies to more than just doctors, right? Yeah. Like the MIT students that was in that study that you quoted. And one of the things that it seems like it's identifying is that humans in general are losing interest in the process over the output. Yeah. So how do you encourage, especially folks like doctors who are such an integral part of bettering society, to lean into the process and focus less on the output?
I think something that was really interesting that came up in our interviews was how we can actually use AI to scaffold our reasoning processes. So just have it as a checker to, ask you questions, something that you can interact with and have them back and forth with, to again make sure you're, doing yourself the justice of going through all those steps of clinical reasoning.
Yeah, that was something that struck us in the research is, again, how intentional clinicians were about using these tools to actually deepen cognitive engagement as opposed to diminishing cognitive engagement. In other words, right, we were oftentimes hearing they weren't using a large language model to quote unquote give them the answer. They were using a large language model, right, to in some ways add new dimension and possibilities to their own reasoning process. And so we find that really interesting. And so the question then becomes, how do you instill that ethos, right, into all of us, but certainly right into sort of future healthcare professionals, not just doctors, but along the entire sort of, pipeline. And so we find that, really interesting. And again, we think in some ways, right, it will become a requirement, right, to sort of emphasize this need to really be vigilant about your own cognition. and ways in which you can sort of deepen cognition as opposed to diminishing cognition. And I think for us, the other thing was we're always, having conversations at IC Squared about, what's the value of humans in an AI augmented world, right? As these systems become more and more quote unquote intelligent, certainly more and more capable. What's our value? And that was something that we tried to spend a lot of time thinking about with the clinicians. What's unique about humans? What's human superpower in the context of AI? And then we think a lot of what we're learning here are examples of how clinicians sort of reassert agency, sort of reinstate the significance of humans in the clinical enterprise.
Thanks all. This is super interesting. I wanted to ask about methods, the methods here, and more broadly. I'm gathering that you're working qualitatively here with a set of interviews, and then are you looking at a landscape of studies of AI in medicine and the use of AI by symbolic analysts more generally that are both qualitative and quantitative? Is some of the work you're talking about undertaking with Dell, for example, going to be quantitative survey research? To what extent are you working the ways that you're working because you feel like you can make that contribution? To what extent is it because you feel like the methods you're choosing are the best methods for the job?
Yeah, it's a great question, Sam, thanks. Yes and yes, right? And so the project with Dell, right, will be sort of multimodal in terms of the data. There'll be a quantitative component, a qualitative component. And we think, right, what we'll do is just add additional sort of empirical richness to sort of studying precisely the kinds of things that emerge through these interviews. It seems like we might get access to a virtual environment, right, where clinicians, if it's medical students, if it's residents, if it's faculty, these sort of simulating a patient experience, and have access to video, have access to transcripts, the degree to which we design is so that they're interacting with a large language model in that process somehow, ways in which we can quantify and analyze that data as well. But we trust and really think like these initial methods were so important in terms of just opening up opportunities to sort of, what are the right questions, right, that then might lead to a project like this Dell project where we can then introduce other kinds of methods.
So this qualitative project not only provided us these aspects of what's happening in the medical field, but also it opens our perspectives, what might happen, like all possible concerns and risk that clinicians must consider. And by interviewing clinicians with different specialties, actually it provided us a great opportunity to understand what's actually happening in the real world setting.
So I'm a 30-year clinician myself and now involved on the AI side. I'd love feedback from especially the nursing and pre-med sides around your thoughts on clinicians building a body of knowledge that they trust, building that walk-in. Intuitively, I have a direction I want to go versus trusting AI. And, do you have approaches you would recommend for let's train someone how to use AI and see if it matches intuition, or use intuition and see if it matches AI?
That's a really interesting question. Yeah, I've never thought about it in that way. But, Sookja, any thoughts?
It works both ways. It provides also learning opportunity as well as validating the AI outputs that I guess that clinicians didn't think about. So, for example, we had this interview with a clinician talking about there was one case, and the younger came to the clinic, and since it was young and thin, they immediately thought about anorexia issue. And that's like the human's biased idea that it comes up right away, what's happening, and then based on also their clinical experience, they immediately think about just fixated on that idea. However, like they went through so many like tests and then diagnostic tests, and it came out like nothing was like applicable for whatever they were thinking about. And it turned out one medical student, he was using Elizabeth AI tool, and then he entered all the symptoms, and it recommended, actually, it was Addison disease. Yeah, and so like there's the case that doctors never thought about, they were biased. However, AI could help clinicians to expand their like clinical reasoning process.
Yeah, if I can just say a little bit on that as well. That's a good question, and my first thought is that we should build our body of knowledge first, right, before introducing AI. But that's also a question we've came across, is that like when should we introduce AI into different steps of the medical education, right? And we also had conversations about some parallels of other technology, right? Like we think about using calculators or the GPS, like we lose some of those skills, but at what cost, at what benefit? Is there a net benefit there? And I think that's something that is really interesting and should be studied further so we know the right answer to that question, right? Yeah, good question.
I had mentioned in the past forum that I'm teaching first-year medical students, and it's now 54 years since I was a first-year medical student. And the biggest difference I find is that I and people in my generation were accepted to medical school and did well because we could memorize stuff. And if you could memorize a lot of stuff, you had a good time in school. Now, the data that's coming at you, you know, everybody talks about the fire hose of data that you can't possibly drink, is just so massive that memory is not the key. And knowing where to go to find the stuff is the key. And that's what should be taught and is being taught, I hope. But I find that the biggest threat to that, aside from the fact that people seem to have a 3-minute concentration limit at a time now, attention span, is that the amount of either deliberately false data or misguided data that is available is a real threat to using that, because it's very hard to validate what's real data. And if you have somebody telling you that, you know, vaccinating kids is harmful, that really, it disturbs me. And I think that's a real threat to the use of AI the way it should be used, to validate, to open the spectrum of what you should be thinking about, because you can't know it all.
Yeah, I think it's a really important point. And, you know, Tu-Quyen mentioned, right, these concepts of deskilling, misskilling, and never skilling, and that would be an example of misskilling, right? And AI basically, you know, how do you navigate, right? And how do you discern, right, the quality of information, the accuracy of the information, so that you aren't led down the wrong pathway? And so these are issues that I think are really important, and something certainly, you know, that we're thinking about in this work. And I love the point, right, that because this came up in interviews as well, right? You know, clinicians noting that just the amount of information, right, that they are now required to memorize, and, you know, the medication, right, the alternative medication. I mean, it just goes on and on and on. And so your point, right, is not so much about necessarily, some things they said you do need to basically learn, and there's some foundational, right? Sort of figuring out what's foundational, right? What's critical, you know, what are non-starters in terms of if you're going to be a physician, right? These are things that you absolutely must know. And I'm in no position to sort of determine what that is, and our colleagues at Dell would certainly know much better than we would. But what we learned, right, is that, learning, not only learning where to go, but in terms of a large language model, then learning how to navigate your interaction with that. So this phase 2 that Sookja was talking about is incredibly exciting, right? Insofar as we found just really interesting sort of strategies and techniques that clinicians were deploying in terms of how they were interacting with these systems, right? So we hear the term collaborating, we hear the term teaming with AI, but what does that really look like? And then how does that translate right into decision making are things that we were trying to understand. And I think we are getting the sign that we are done. Thank you so much.